So over to Dr. Debasmita MAJHI for her talk.
Yeah, thank you. So after all those good technical discussion, let's spend some time in the deep forest of Odisha. So I'll take you through the journey of tribal Odisha eye disease study. So the tribal people have also all the rights to get proper coverage under the universal health scheme to the full range of quality of health services without financial hardship. In Odisha, the 9% of the tribal community of India are residing, and there are 4 districts where more than 50% of the population are the tribal community, and there are 13 communities who are particularly vulnerable tribal group. For example, the Dongriya community, they are backward, isolated, they have poor literacy rate, they are small and diminishing populations. So they reside in the Niyamgiri hills of Raigada district, mostly 3 blocks of the Raigada district. So with the support from Ministry of Tribal Affairs and the SCSTRI and OPLIP, LV Prasad Eye Institute in 2021 started this journey of tribal Odisha eye disease study in the Raigada district, where our secondary center is already there. We underwent the door-to-door screening for the Dongriya community, did a few cataract surgeries in the community, provided a pair of glasses to the community. These things were very new and first time for the community, so there are a lot of resistance, lot of barriers. With all those barriers, we are able to at least screen 89% of the target population, and we found there are more than 7% prevalence rate of uncorrected refractive error and senile cataract in the community. Though people were happy with the pair of glasses, and we published it and we submitted the report to the Ministry of Tribal Affairs. But unfortunately, only 40% of the population could avail the services because of the barriers. So again, in 2023, we went to the same community with the support from Ministry of Tribal Affairs to understand what was the impact. So we tried to only touch the population who were screened more than 30 years of age group. And we went through the focused group discussions, tried to examine the left out patients at their doorstep, doing refraction and providing pair of glasses at the doorstep, trying to motivate the left out cataract patients whether they can avail the surgery at our secondary center level. With all the effort, we could only achieve a few more number of cataract surgeries, and we could distribute another 1,000 glasses to the community. And we submitted the report to the Ministry of Tribal Affairs. By that time, the ministry offered another district, that is the Mayurbhanj district of Odisha, with the help of OPLIP, to start the same eye screening services. The Mayurbhanj district is in the northern side of the Odisha, and it was nearer to Baleshwar and Keonjhar district, where LB Prasad has its own secondary centers. And it has a huge load of tribal community, around 56% of the tribal community, the population of Mayurbhanj district. These are the secondary centers of LB Prasad. So with the support from Ministry and OPLIP, we started this journey to reduce the burden of visual impairment and improve the eye health of the PBTGs residing in the Mayurbhanj district. So there are 3 PBTG communities, that is the Lodha community, Hilkhadia community and the Mankidia community, who are residing in the Mayurbhanj district. I will go through a small video. Dr. Anurag. So after the journey of tribal Odisha disease 1 and 2, this is the community of Lodha community who are residing mainly in the forest. Their livelihood is completely on the forest material, and they live in the jungles. And they are highly addicted to alcohol and tobacco since the early childhood. So with the support from the OPLIP team who are residing in the Mayurbhanj area, we started and screened the team works from the tribal community, trained them at our Keonjhar secondary center. Then we started the journey in the difficult jungles. These populations are residing only in the deep forest, where the vehicles can't go. The team workers, they traveled kilometers with the bags. They communicated with the Anganwadi workers of the PBTG villages. And this time we modified, we took all the handheld equipment as a mobile vision center to the doorstep. Then the door-to-door screening started. So here most of the female pupil they participated. As you can see, just like a mobile vision center, anterior segment evaluation, posterior segment evaluation, intraocular pressure measurement and glass prescription was done at the doorstep, and with the teleophthalmology they were connected with the command center. Few children who were in the school they were screened, and we are happy to find that very less amount of refractive error was found in this population. It was very difficult to convince the Lodha community for cataract surgery. With difficulties, we were able to at least perform around 70 to 80 cataract surgeries till now at our Keonjhar and Baleshwar secondary centers. So those people where we provided the glasses, we are happy that they were able to pursue their occupation further. So this journey is on the process, the project is ongoing. So for the Lodha community, the livelihood is either forest or sewing the leaves. So with the pair of glasses, the females are getting now more motivated to avail the glasses, but they are not motivated to go to the hospital. They are ready to take the glasses if it is provided at the doorstep. For cataract surgery, the most important barrier till date is that there is no felt need. If there is a felt need, they don't know where the service is available, and these families are nuclear families where after marriage the boys and the girls they leave their parents. So the most of the parents and the females they are staying alone, and they are not able to take one handful mouth of food also because of the both eyes cataract. But there is nobody to bring them to the hospital. So they are the pictures with the help of this time with teleophthalmology we are able to take care of the patients. So the few of the families where both husband and wives are motivated both for glasses and cataract surgeries, and we found the load of visual impairment is within 8 to 9% among this community, and advanced age and lack of education was the most important contributing factor till now. Whatever data we have analysis, the refractive error load is quite high. But in Jasipur and Moroda, these are the two blocks where the load is more, and there are more rejection in the blocks. When we compared this community with our previous community that is in the Rayagada, we found the load of refractive error is still now comparatively low, and the load of cataract is slightly high. So what we learned from all these four communities that with one unique model we can't work with the particularly vulnerable tribal community. Every time we have to customize our procedure, and if we are finding this kind of blocks where the load is high and rejection is high, it's better to build a vision center, fixed vision center there instead of going every year with the mobile vision center. So we are thankful to our leaders, our supporters who helped us through the journey. The journey is still continuing. Thank you.
Thank you so much. Just one question. If
nice presentation. It was very comprehensive. Just one simple question. In your view, what would be an ideal tribal eye disease study that you would formulate?
So in till now what I have learned with these two districts, that an ideal will be always to establish a fixed healthcare service near to the community, to recruit the people of their community, train them, then only their health seeking behavior will change within few years. But not with one time of projects, it will never change.
Just follow up. How will you collate all this information to have a more comprehensive thing for the state?
For the state, wherever we have 13 PVTGs in 14 districts of Odisha. If we can connect those areas with the nearby healthcare facility, either a secondary center or such kind of good CSC or PSC with the community, so then only we can resolve the problems. But first thing is their population should be recruited and their people should be trained. Then only they can motivate other people. Otherwise, it will never happen. Because this is possible because two girls from the Dongriya community are working in this team. So they are ready to motivate the other community peoples. Otherwise, this difficult work is not, and all are tribal children, the team who is working, is not possible with our kind of population. I felt a lot of difficulty whenever I was in the field that time.
thank you, Dr. Debasmita.